Week 5 case study, we have an 86-year-old female presenting to the ED with a caregiver for weakness and just not acting right. Her past medical includes dementia, hypertension, CHF, and a hernia repair. Home meds are lisinopril, metoprolol, furosemide, and amlodipine. The caregiver reports the patient is usually alert and oriented to self, people, and place, but disoriented to time with short-term memory issues. Caregiver denies fever, weight changes, or falls, but does report a poor appetite. Unaware of chest pain, shortness of breath, cough, or leg swelling, denies changes in urine smell frequency or amount. Vital signs are BP 105/50, heart rate of 109, respers are 14, temp is 37, and 96 on room air. She's normocephalic, atraumatic Perla, S1 and S2, and her mucous membranes are dry. Decreased skin turgor, clear breath sounds throughout. Bowel sounds are hyperactive in the right upper quadrant. No CVA tenderness or suprapubic tenderness. No vomiting either. So diagnostics, we got an ECG, a troponin, a BMP, an LFT, type-in screen, CBC with diff, CSR, CT head, urinalysis, urine culture, blood culture, BNP, lactic acids. Those are all pending. In the ED, she got 2 liters of normal saline. So, based on the case study, how would you demonstrate clinical reasoning? And I'm saying that NP practice processes can be informed and improved by using a systematic and dependable approach, or defendable approach, for clinical reasoning. Thinking about thinking and learning about learning is inherently interesting and germane to the human experience. Becoming aware of how and why we think and learn can help us become better practitioners and avoid pitfalls such as erroneous reasoning and biases. I find myself working toward developing pattern recognition skills, as well as my knowledge base to connect the dots between syndromes, presentations, diagnostics, and differentials to create a detailed and connected web of knowledge that will allow me to identify and follow patterns while being aware of the important do not miss outliers. Yazdani, Hasanzadeh, and Hosseini in 2017 found that most practitioners default to the system and recognize that a novel presentation cannot be satisfied by pattern recognition and does require other methods. In other words, you have to look deeper. In this case, I would recognize a pattern of dehydration, including an elevated pulse, a diminished BP, dry mucous membranes, diuretics in the meds, and an apparent presumption of the ED doc as well, considering a 2-liter infusion. Clinical evidence and indicators for the pending tests. I did not go through every single pending test. It's actually somewhat difficult to find sensitivity and specificity information that's current and accurate toward all of the things on this differential. So I spent what I thought was a fair amount of time, and what I've got is that electrolyte abnormalities like hypokalemia, which she could be suffering from with diuretics, are pretty sensitive, although subject to human error in lead placement and because of artifacts. And it's interesting, I did find a study on an AI that had a 96.7% sensitivity rate and a 93.3 specificity rate for seeing hypokalemia on an ECG, which I thought was pretty cool. BMP is indicated to determine electrolyte balances that could be caused by dehydration due to diuresis or poor PO intake, for which this patient is at risk. It would also provide some information on her kidney function. It's notable that while creatinine is specific to kidney function, it lags behind actual function as a marker, and is actually only sensitive after about 50% of the nephrons have already been impacted, making it a rather late latent and severe, though not necessarily sensitive marker. Hussein Sayed, 2022. A CBC is indicated due to her altered mental status, slightly elevated pulse, and slightly low BP. Fever can be diminished in elderly patients, and though this presents more like hypovolemia with possible AKI, we can't rule out a UTI and possible sepsis without a CBC anyway, because again, we'd want to know why she's hypovolemic. I mean, obviously the Lasix, but maybe there's something else going on as well, like a UTI that could have gone septic. So the septic criteria is ever evolving. Since I've been in nursing, it's changed a bunch of times. Currently, CRP is one of the more common indicators on different algorithms, though it is both low in specificity and only slightly more sensitive. Slightly higher than low in sensitivity, according to Agnello et al. In 2021. And serum lactate is similar. It was found to have a sensitivity of 67.4% and a specificity of 61.7% when they looked at a 28-day sepsis mortality. So, I mean, definitely if you have a lactate, you need to be worried. So my two open, and I'm curious to know what people find with the liver function, just because she did have that abdominal pain. I'm just curious to know where people went with that, so that'll be fun to see. My open-ended questions are, 1, what's the most expedient and accurate way for the NP to stay current on changes in best practice as it relates to diagnosis? Like, how do you stay up to date on all of the changes? And there's so many body systems and so many differentials and how, things change over time. So what do you do to make sure that you're kind of staying on top of new research and understanding? And then how would you address the changing nature of best practice as you advance? So, what if your facility has a practice standard that's something that might not be, updated? I mean, a lot of places are still using Kayexalate for hyperkalemia, and some of the, indicators are showing that maybe that's not the best idea. So, what would you do in those scenarios, and how do you navigate that and stay up to date with it in the first place? So thank you. I hope you guys are having a good time. Bye.